Welcome to This Explainer. Today, we're going to dive right into the absolute tightrope walk that is hemodialysis. And specifically, we'll be looking at the dramatic acute complications that can pop up. For patients dealing with end-stage renal disease or acute kidney injury, the artificial kidney is honestly a modern miracle. By tapping into the bloodstream, usually through a permanent AV fistula, this machine takes over. It removes metabolic wastes, corrects wonky electrolytes, and manages fluid overload. But as you might guess, anytime we hook up a fragile, complex biological system to an immensely powerful high-flow machine, things can occasionally go wrong.
Here is the agenda for our discussion today. First, the artificial kidney. Second, intradialytic hypotension and cramps. Third, dialysis disequilibrium syndrome. Fourth, dialyzer membrane reactions. And finally, rare hemodialysis emergencies.
Let's start with Section 1, the artificial kidney, replicating a vital organ.
Okay, picture what's happening inside the dialyzer itself. Blood is racing through thousands of these hollow fiber synthetic membranes at a rapid 300 to 500 milliliters per minute. At the exact same time, you have the dialysate, which is this carefully mixed bath of purified water and electrolytes like sodium, potassium, calcium, and bicarbonate. And that dialysate is flowing in the opposite direction at an even faster clip, usually 500 to 800 milliliters per minute. This countercurrent flow is brilliant because it creates a massively powerful concentration gradient. Metabolic waste, like urea, just diffuses right out of the blood while essential buffers move in. So diffusion handles all those invisible solutes. But how do we actually get rid of the physical fluid? That's where ultrafiltration comes in. By manipulating the hydrostatic pressure across those synthetic membranes, the machine literally drags excess water right out of the patient's vascular system. And actually, as a bonus, this creates something called convection, where larger middle molecules get dragged along with the water. But here's the million-dollar question. What happens when we pull that fluid out just a little too fast? The machine has incredible power, but the human body has a biological speed limit for how fast fluid can refill the blood vessels from the surrounding tissues. Which brings us to Section 2, intradialytic hypotension and cramps, the fluid imbalance glitches. Intradialytic hypotension, which is a sudden, dangerous crash in blood pressure, is wildly common. We're talking 5 to 30% of all dialysis treatments. It happens primarily when the machine's ultrafiltration rate outpaces the patient's vascular refill rate. Essentially, we are draining the pipes faster than the body's tissues can refill them, and that leads to severe lightheadedness, nausea, and sometimes the patient just completely loses consciousness. When the pressure tanks, the medical team has to act fast with a really active protocol. Step 1, stop the ultrafiltration. Just stop pulling fluid. Step 2, get the patient flat and elevate their feet in the Trendelenburg position to let gravity push blood back toward the heart and brain. Throw on some oxygen, and if they still aren't rebounding, you push a fast IV bolus of 250 to 500 milliliters of isotonic saline to instantly pump up that vascular volume. And it's not just blood pressure drops. Toward the end of a session, patients frequently get these brutal, severely painful muscle cramps. Interestingly enough, these cramps aren't really a muscle problem. The origin is actually neural. It's triggered by that exact same rapid volume contraction and those sudden electrolyte shifts. It's absolutely miserable and is one of the top reasons a session has to be cut short, leaving the patient with inadequate treatment. To prevent both the cramps and the hypotension, we use a really clever trick called sodium modeling. By starting the session with a slightly higher concentration of sodium in the dialysate and then gradually dialing it down, we keep the blood's osmolality artificially high. That encourages fluid to shift from the tissues back into the blood vessels where we need it. And honestly, this trick is a lifesaver for our next major glitch too. Let's look at Section 3, dialysis disequilibrium syndrome, the osmolality glitch. This one is absolutely fascinating. When someone with severe kidney failure first starts dialysis, the machine does its job and rapidly clears urea from the blood. But here's the catch. Urea crosses the blood-brain barrier really slowly. So suddenly, the blood is totally clean, but the brain tissue is still packed with urea. This creates a reverse osmotic shift. Water gets pulled right out of the blood and straight into the brain cells, causing cerebral edema or brain swelling. It leads to terrible headaches, confusion, and in severe cases, actual seizures.
Because brand new patients, especially those with a bun over 100, are so incredibly vulnerable to this, we have to rein in the machine's power during their first few sessions. We shorten the treatment to just 2 or 2.5 hours, and we dramatically slow down the blood flow rate to around 150 to 250 milliliters per minute. Plus, we throw on that sodium modeling to keep the blood osmolality up, which buffers that dangerous fluid shift into the brain. Moving on to Section 4, dialyzer membrane reactions, the biocompatibility glitch. Sometimes the immune system just flat out rejects the artificial kidney. We see two main types of reactions here. Type A is an immediate, terrifying anaphylactoid reaction that happens within minutes. It's usually triggered by sterilants like ethylene oxide or a really specific interaction between ACE inhibitor blood pressure meds and AN69 membranes. Type B, on the other hand, is much milder and delayed. It usually hits about 15 to 30 minutes in, causing chest or back pain, and it's triggered by the body's complement system reacting to older cellulosic membranes.
Now, with a type B reaction, the symptoms usually fade as the session continues. But for a type A reaction, urgent action is required. You have to stop the machine immediately, and this is crucial. You absolutely do not return the blood in the circuit back to the patient. That blood is contaminated and reactive. You clamp the lines, abandon the blood, and treat the patient aggressively with epinephrine or antihistamines. Let's wrap up with Section 5, rare hemodialysis emergencies, mechanical glitches. Even with all our modern safety sensors, mechanical things can just break. Take an air embolism, for example. Any negative pressure zone in the circuit, like a slightly loose lure connection or a tiny hole in the pre-pump tubing, can literally suck air into the line. If those air bubbles manage to bypass the detectors and enter the patient's bloodstream, they can travel straight to the right side of the heart, creating a fatal blockage. If you suspect an air embolism, maybe you see foam in the line or the patient suddenly coughs and clutches their chest, you clamp those lines instantly. Then roll the patient onto their left side and elevate their feet. Why the left side? It's a neat anatomical trick. It traps the air bubble right at the apex of the right ventricle, keeping it from being pumped out into the pulmonary arteries. This buys you time to blast them with 100% oxygen.
Another super rare but critical mechanical glitch is hemolysis, the actual fragmentation and bursting of red blood cells. This can happen if the dialysate heater malfunctions and spikes above 47 degrees Celsius, if contaminants like bleach sneak into the water, or even just from the mechanical stress of kinked tubing. Just like a type A reaction, if hemolysis happens, stop everything and do not return that hemolyzed blood to the patient. It is packed with intracellular potassium and will cause immediate, life-threatening hyperkalemia that can literally stop the heart. So, what does this all mean? When you really look at these complications, from the raw physics of ultrafiltration crashing someone's blood pressure to the chemistry of osmotic shifts swelling the brain, it leaves you wondering just how incredible this daily medical tightrope walk truly is. We are constantly balancing immense mechanical power with fragile human biology, replacing a vital organ with synthetic fibers and purified water. It really makes you think, what other technological miracles are we completely normalizing every single day, and what hidden complexities do they hold? Keep that in mind and keep learning.